Today's lecture is about the use of computers in maxillofacial procedures. You will find that it is now an established thing, and it will change the face of maxillofacial surgery in the coming years. The first report was by Finger in 1997, who used a CT scan to make a customized mandibular reconstruction. He was using the CT scan images in 2D and putting one picture over the other in a manual form to represent and make the 3D model. But in the late 90s, with the introduction of DICOM file formats that allow the computers to import the DICOM files and make the 3D model electronically with simulation softwares, the things started to go into action. And the study of Perry et al., it actually pulled the attention of the whole medical industry about the abilities and of the 3D modeling. He made a 3D orbital model based on the CT scan data of patients with trauma mainly, and even with tumors, and made a 3D model of the orbit and the orbital floor to customize fixation devices and meshes. Now we use computers for analysis like encephalometric tracing and impacted teeth position. We use the computer for planning and the application of a surgical guide like an implant placement in orthognathic surgery, resection and reconstruction, and traumatic injuries, and we can use them in navigation systems, and that's outside the topic of today's lecture. For cephalometric analysis, we know we can do the cephalometric analysis on many softwares actually, and the good thing about it is that you place the points and you change the analysis technique and it changes immediately. And if you're going to refer the patient to another specialist just to take his opinion or to continue on the treatment, the case referral is much easier. Also, we can scan the photos and we can digitize the photos. Then we can superimpose the photo over the picture and we can predict the surgery and we can predict the treatment outcome with two superimposed profiles, so we can see the changes that would happen after we do the correction, whether orthodontic or orthognathic. In impacted teeth, it's much easier for everybody to see the tooth, the impacted tooth, like a maxillary canine in its full shape in 3 dimensions, and you can see where is exactly the crown and where are the roots and the relation to adjacent structures. You can see the roots of wisdom teeth that are inside, really inside the maxillary sinus, and I can tell you that in this case, I couldn't see that distomolar impacted except when I did the 3D model, because it looked like one tooth impacted. Here is the first molar, second molar, this is the third molar, and this is another molar, which is a distomolar that was evident only after doing the 3D models. Also, we can see the relation of the inferior alveolar nerve to teeth, and we can see how close the proximity and relation of the roots to inferior alveolar nerves. And in some cases like that, we have a small cyst around the tooth. And you know, we access these teeth always from the buccal side. So when we open a window here, with the first thing to do before even reaching the wisdom tooth is damaging the inferior alveolar nerve. But when you do that in using the 3D and the 3D modeling, you can see actually the tooth. This is a cut section. We can see the tooth. We can see the space for the cystic lesion, and we can see the inferior alveolar nerve, and we can take everything out and check the relation of the tooth and nerve alone to decide where to go, from where to reach and access the tooth, and where to put your tooth sectioning. Here is a very interesting case. I can see in the CT scan cuts, the regular CT scan cuts, you can see the roots and you can see the nerve. It's here. But I didn't realize until I made the 3D model that we have a tooth that is having a curved root that is hooking around the inferior alveolar nerve. Either I break the tooth and try to get the roots out and damage the nerve, or I know from the start and do whatever necessary to retrieve that tooth completely without affecting the nerve. In dental implant placement, I think this is the most common thing to know about. We take the CT scans, usually the axial ones. We create a panoramic and the 3D model. We do that by what we call segmentation. We take the whole data from the CT scan and we select the area we need. And here we selected the mandible. Then we can place even prosthetic teeth inside. We can visualize the panoramic on sections, and it can give us a wealth of in-depth information, like exactly in this case, we have a twin inferior alveolar canals, something that we could have never seen in the classical x-rays. We have also tangential views here, so we can place the implants into the corresponding artificial teeth. We can see that they are parallel on this side and the other side, and in case of full arches, we can check the parallelism. We can see the need for angulated abutments, and actually we can place angulated abutments here to check the path of insertion of the future prosthesis. In mandibular resection and reconstructions, what is the problem? We have a patient with a mandible that have a tumor, and the mandible is bulging as a result of the tumor. So what we do is we place the reconstruction plate first, and we drill holes for it. Then we cut the piece that we need to take out that is affected with the tumor. We do that to preserve the condylar position. But after doing that, we find out that we contoured the reconstruction plate to an over-contoured position. And that's not what we need. We need to do the proper contouring. So we did that, and we were used to do that with the use of two plates. We bend one plate on the bulgy mandible, then we resect the mandible and fix it to position with the first plate. Then we use another plate where we bend it and place it to the position we need. Then we take the first plate out and throw it away. And this consumes a considerable time in the operating room. What we do now is we have like this lesion in occupying the whole body and ramus of the mandible, do the necessary segmentation as we've been through. Then we do a resection planes. We define where to do the resection from where to there, and then we segment the area to be resected, and we fabricate a resection template. This would fit on the mandible exactly to show us from where to cut the anterior and posterior cuts. After that, we take the other part of the mandible from the other side. We do what we call mirror imaging, and we place it in place of the resected piece. So we restore the mandible, and we restore it to an exact symmetry, the right side to the left side. And we can do that as long as we did not cross the midline. And even if we cross the midline now, we're developing the necessary techniques to do that, even if the original lesion was crossing the midline. Then we do what we call the bending template. Instead of 3D printing of the whole mandible, we can do that, but we can adjust this bending template and print it alone, so we bend the reconstruction plate before the surgery on that template. So additionally, we did something, didn't work out very well. We take the teeth out, then this is the reconstruction piece, and we were making it in a 3D, labeling it with BMP2 and bone marrow extract in order to do the resection, place the bone substitution material. We use the SCPC, which is the silica calcium phosphate ceramics with nanopores, and we add BMP on it. We add bone marrow extract on it, so we do the resection, place this in place, and fix it with the reconstruction plate and close, and we finish the reconstruction in one go. This didn't work out very well. We're still studying that. This is the resection template, and this is the reconstruction plate template, and that is the surgical cases. We do here a submandibular incision, and this is a subperiosteal dissection plane. When the lesion is perforating the cortex somewhere, we do a supraperiosteal dissection plane and leave the periosteum on top. Then we place the resection template, and it fits perfectly well. Then we cut from here to there, so we cut exactly the same as we did on the modeling on the computer. This is the replica that we took from the other side, and it helps to position the segments together, and then we start placing the reconstruction plates and I can assure you that all the reconstruction plates were fitted in place very well with almost no adjustment. The technique is extremely sensitive and accurate. And here, after we fixed, we placed the bone substitution material that was labeled with BMP2 and with bone marrow extract. Then we can see the patients. You see a little puffy here, and that is usual with the use of the BMP. Sometimes it lasts for many as 4 to 6 months post-operative, this puffiness. And we can see that the bone graft material, actually it starts to lose material, it starts to crack, but it was never resorbed full and replaced by bone. We could replace a few areas with bone. Most of the areas that the bone graft resorbed was replaced by cartilage, and there are lots of residual material. We're trying to look for different materials to do that, but we didn't reach that yet. But in the CT scans, in the post-operative CT scans, as you can see the mandibular symmetry. And I've done that for years and years. I'm an old guy without the use of computer guidance. And now with the use of computer guidance, when I look back even to my cases that I was proud of, I can see differences now I can avoid, and I can give the patient the exact symmetry. And you can see here, this is the mandible, and this is the reconstruction plate. And when you take from the inside of the reconstruction plate to the inside, to the outside of the mandible here, and you draw a vertical line and measure, you would be surprised that you can have like 83 millimeters here and 84 millimeters to the other side, and the symmetry is outstanding, actually. So in another use for the orthognathic surgery, we start with the bilateral sagittal split osteotomy. What was the problem, or what we thought was the problem, is sometimes when you do the sagittal split, you align the condyle to place manually. And after you fix that, if the condyle was not seated well, then it seats after the patient awakes, and the effect of the muscle relaxant goes away. So the muscles pull the condyle in place, and you end up with an immediate open bite. And people try to do, we do that manually here. We push the segments and position them. And along the years, many what we call condylar repositioning or condylar positioning devices were introduced with actually no more value than the manual repositioning, so most of us were not using them. Now we're doing that computer guided. This is, for example, a case. This case went through bimaxillary surgeries, but we'll concentrate now on the mandible. We do the 3D model, and we can see when the patient has some metal artifacts, like braces, like metal fillings, like a bridge. It gives us lots of scatter, so we scan the models. We do a CT scan for the models, and we do what we call image fusion based on the 6 points. We assign points here in the 3D model, and we assign the corresponding point on the CT scan. Then the computer takes the model picture that is error-free, that is scatter-free, and put them on the teeth section, so we can see the teeth on the virtual model quite accurately. Then we design the CT scan cuts, and we start now by doing the template that fits on the what we call the proximal segment and fits on the distal segment with the use of these two rods. And we fix that preoperatively, then we take it out and fit another one, identical one, with the difference would be in the rod length and the rod direction for the postoperative phase. This is a demonstration of the models being moved according to the planned postoperative occlusion. Then the arms are now removed, and we recreate new models like that. This is what happens in the operating on surgery time. We can see this is a blue line. This one is transparent. I don't know if you can see it or not, but actually, especially in setbacks, I found a gap in between the segments. We always, when we try to position the condyle, and we use what we call the transbuccal trocar, that we used it to drill through and place the screws, and we put the bone segments together and we press them on each other so they contact each other. And we thought that we're doing a good thing, but when we tried to adjust the condylar position exactly on the computer, I found out that in setbacks, especially in setbacks, but even in mandibular advancements, you have a space in between the segments. And when we push those segments to meet each other, actually the condyle rotates inwards. And this explains why we do orthognathic surgery for some patients who never had joint problems before, and ending up with a TMD, with a temporomandibular joint disease after the surgery, we were rotating the condyle inwards in case of setback and outwards in case of advancement. This is because the mandible is a horseshoe that gets wider as you go back. So when you move the mandible forwards, there is a premature contact between the segments and the body of the mandible. Then after that, we fix it, and this is the post-op. I did 2 slots to determine where to drill, so you do not end up doing a perfectly good split. Then we drill to place the screws, and you find yourself accidentally drilled into the canal. So I did additionally these 2 slots for the first 2 screws to fix the mandible. And as you can see, the screws are away from the inferior alveolar nerve. Still after? Okay. To continue on orthognathic surgery, we tried to do a splint for the Leafort 1 osteotomy. After the analysis and stuff, we did the 3D model, and these are the 2D scan cuts, and this is the maxilla. And if you can see critically, this pink color is projecting through the nose. This is the maxilla after we move the maxilla upwards. And by the way, that was I don't remember the date exactly now, the first computer-guided splint to guide the maxilla in impaction position. We had splints before that one that guides the maxilla forwards, backwards, guides the maxilla tilting, backwards the maxilla to rotate right and left, but there was no computer-guided splints that guide the maxilla in impaction or in vertical position before that one. Anyways, we import the 3D model to some of the CAD systems. Actually, this is a commercial product called 3D Max, and we start devising the splint that is tooth bone contacted splint. Here we do a box, and this box we do what we call on the software Boolean operations. We ask the computer to remove the teeth from that box, so it ends up as like a wax bite that it fits in place. And these arms fit on the zygoma. We'll see them now. And the connecting arms, when having holes, when they fit inside each other, that denotes the maxilla in the exact planned postoperative position. This the shape of the splint in pieces. And now here we open the cut. The tissue is open. I started by doing the classical measurements that we do without the computer-guided splint. I still do it. I was a little afraid that one of my splints may not fit, so I can continue in the conventional manner. Now I stopped doing this this step. And this is the pterygoid. We did the cuts from the nose back to the above, a little above the tuberosity, and this the pterygoid chisel is separating the pterygoid plates, and the nasal spine osteotome separating the nasal spines, and here we're cutting the lateral wall of the nose. Then the maxilla, what we call it, we down fracture the maxilla. We grind whatever necessary to, then we place the 2 splints that fit just in front of the zygoma with the 2 rods, and we move the maxilla to fit. And when these rods fit inside the splint in both sides, this makes sure that we adjusted the maxilla to the exact needed postoperative position. We start applying the bone plates, and now the maxilla is fixed. What I'm trying to show here, that the patient is quite early postoperative and still having the arch wires in place. She had that much of a gummy smile, and now when she smiles, she's on the gum margin. That's her profile. The X-ray to show that we did actually we did work in the maxilla and in the mandible as well. In maxillofacial trauma and zygomatic complex reconstructions, mainly in the zygoma when it fractures in more than one location, in the operating room it is difficult to position those pieces together. So what we did is taking the CT scans, doing the segmentation, and here, as you can see, the zygoma is broken in lots of places. We segment the pieces, and we take the zygoma, the frontal bone, the orbital area with the zygoma from the unaffected, unfractured side, and we superimposed it. It's that brown thing on the other side. Then we start putting the puzzle in place inside the zygoma, so to end up with a right and left identical zygomas, and we fabricate a series of stents that would fix the bone to the desired position. I also printed in 3D the orbital floor to make the orbital mesh contouring before the surgery, like that. This is the orbital floor, and we contoured the orbital mesh to fix that preoperatively. And here is a bicoronal flap, and this is the splints in place, and this is the lateral the lateral wall of the orbit, and this is the reconstruction of the orbital floor with the orbital mesh. Additionally, I did some measurements to know there is a difference like 4 to 7% from the right eye to left eye in normal individuals, and I reached by trying to copy the unaffected side and copy that to the affected side with differences below 4%. And results, especially with enophthalmos and the ectropion, unbelievably good. This is the post-op, and as you can see, here is the orbit, and we regained the orbital floor to the same level as before. Here is the zygoma that was broken and displaced, and it returned straight and back to position, and we restored the level of the eye pupils, and the patient does not have any dystopia anymore. For the mandibular fracture reduction, sometimes we have a mandible, and the mandible is broken, but the patient does not have enough teeth to fix the occlusion together in order to have what we call maxillomandibular fixation, to fix the mandible with closed methods, or we cut him open and fix it with bone plates and screws. Sometimes we do not have enough number of teeth to do that, so we're doing that manually, and we end up with the small disturbances in the bite, and we say, okay, no problems, the denture would correct that. But now we can use the same technology, and here is a mandible fracture in an edentulous area, and we do the 3D modeling, and then we reduce the mandible to its proper anatomical position, and we fabricate a guide that approximates the mandible and reduce the segments back to where they were before trauma. And here is the submandibular incision here, and this is the fracture of the mandible, and this is the stent that we used to fit the mandibular fracture together, and here with the plate application, and we took it out, and this is the pre and post-operative CT scan superimposed on each other. The yellow is the pre and the red is the post-operative, and we can see they almost match identically, so we know that those splints guide the surgery the way we plan it preoperatively. Thank you.